Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ, free 2-week sessions again. So tonight we are going to do Cardiology Theory 1, right? So I hope you guys are enjoying our sessions so far. So we have finished psychiatry, just one class, not the full psychiatry yet, but we do finish the psychiatry in our rest of the course. And also, a few days ago, we had a question solve class where we discussed the tips and tricks to solve questions, right? Today, we are going to do a theory session on cardiology, which is a very, very important topic for your exam. So let's start. Yes, Dr. Mahir, the recording will be available. Before we start, let's start with the simple physiology of cardiac system. Okay, so let's watch the video first.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
Okay, in a very short way, the video actually described that how our cardiovascular system works, right? So this is important. Many of you might have forgotten how cardiac system really works. And for today's session, it is important. We don't want you to memorize things. We want you to understand things, okay? So we will go through a little bit of cardiovascular system, and then we will start with further discussion. So let me discuss how cardiac system works first, and then we will move on. So if we look over here, so let's say that's the heart. And then we have got our fourth chamber of the heart. So you have got right and left atrium, right and left ventricle. We know that between right atrium and right ventricle, we have tricuspid valve. Between left atrium and left ventricle, we have mitral valve. And then we have got pulmonary valve and aortic valve. So blood from superior vena cava, which will carry blood from the upper extremity, and blood from inferior vena cava, which will carry blood from lower extremity. So these bloods are all deoxygenated blood, right? So this deoxygenated blood from the body will be coming to the right atrium. Through the tricuspid valve, blood will then go to the right ventricle, and then through the pulmonary valve. So that's your pulmonary valve, let's say. So from right ventricle, blood will then go to pulmonary artery through this pulmonary valve. Up to this, all the bloods that we have got, these are deoxygenated blood. Now, pulmonary artery will then carry this blood to the lung. And in the lung, there will be oxygenation of this blood. Okay, so in the lung, this deoxygenated blood will be oxygenated, and blood will be carried by pulmonary vein to the left atrium. So pulmonary vein will carry the oxygenated blood. So through the pulmonary vein, now blood moves into left atrium. Through the mitral valve, blood then goes to left ventricle. And then from left ventricle, blood will go to the aorta and supply blood to the whole body. And that's your aortic valve. Okay, so this is the basic knowledge that anyone who is actually going through cardiology should know it. Okay, so does it make sense for everyone how the cardiovascular system works? Anyone needs me to repeat it? And Dr. Mohitosh, there will be 2 cardiology classes. Once again, okay, so from superior vena cava and the inferior vena cava, deoxygenated blood will go to the atrium, the right atrium, then it goes to the right ventricle. Through the pulmonary valve, this deoxygenated blood will be carried by pulmonary artery, and it goes to the lung, becomes oxygenated. Then pulmonary vein will carry this blood to the left atrium. Then through the mitral valve, blood will go to the left ventricle. And then from the left ventricle, blood will go to the aorta. And then aorta will take the blood everywhere. Okay, so that's the basic cardiovascular system and how it normally works. Now, you all know that there is systole and diastole. So during systole, there is contraction or a squeeze of heart happens to pump the blood out of the heart. So systole means contraction. And during contraction, the heart will pump out its blood to the whole body. And the diastole is something when the heart relaxes. So heart will relax so that it can take blood from the superior vena cava and inferior vena cava. Okay? If somehow the heart systolic function is impaired, then heart cannot pump this blood to the body, and that's the time you get heart failure. And that heart failure is what we call as systolic heart failure. And when the heart cannot relax enough, maybe because there is constrictive pericarditis and a lot of other causes, when heart cannot relax, then it cannot take enough blood in, so it cannot pump enough blood out, and that also causes heart failure, and that is what we will call as diastolic heart failure. So this is the basic pathophysiology behind heart failure. Our main topic of tonight is not heart failure. Heart failure will be discussed in the next class, but this will definitely help you to understand. So for cardiology, this is what we are going to follow. So John Muttag has a couple of chapters. So chapter 30, 59, 75, 6, 7, 8. These are all cardiac chapter in John Muttag, 8th edition. We also take a considerable amount of help from a step 2 CK Kaplan and sometimes RSCGP guideline. Your lecture note has almost everything that you need to prepare, and we also go to John Muttag to read a little bit about chest pain. And then after you finish the cardiac class, go to a Q bank, try to solve some of the Q bank from cardiology and see if you are getting the answers right. Once you finish a little bit, you don't need to finish the whole cardiology from a Q bank. Just solve 20 or 30 questions, find out if you are getting the answer right. And once this is done, then you can go to our portal and then appear the mock exam, which is cardiology mock exam. So this will be your step-by-step preparation for any theory that we are going to discuss. Okay, so you go through the lecture note, you go through my lecture first, and then if we ask you to read anything extra, you read it. Finish the lecture note in detail, do some question from QBank, and then appear the mock exam. Okay? Moving on to chest pain. So we will discuss all of this, the QBank thing, and after the 2 weeks free session is done. So we will give you a QBank in your Facebook course, like your course group in Facebook, where you will be able to access some of the QBank, and those QBank will have like subject-wise questions. So you will be doing that. And John Murtag has been already uploaded in the course group. So this is all for course students. So if any of your course student, you will get everything in your Facebook group or in the portal. So books are not given in the portal. It's already has been uploaded in your course group. Same with the Kaplan step to CK. We don't need to go through the master the board. Just Kaplan step to CK will be enough. Okay, moving on to chest pain. So chest pain is very, very important. Our tonight's session is mainly focused on just chest pain. So as you can understand that chest pain is a very, very important topic. That's why we take just one class on chest pain, because you will definitely get questions from here. So what are the differential diagnoses of chest pain? Now the notes are a combination of John Murtag and Kaplan Streptosike. But once I finish the note, I will go through the John Murtag chest pain chapter just to show you what are the important things that you can also read from John Murtag. But once we take a session, there is no need of any extra reading from John Murtag, because anything that is important, that will be discussed by me. Okay? So chest pain is not only just related to cardiac system, it can be related to a lot of other organs. But as part of cardiology, myocardial infarction, angina, pericarditis, these are common causes of chest pain. Aortic dissection can be a cause. Respiratory, like pulmonary embolism, pneumonia, pneumothorax can be a cause. GIT, very commonly peptic ulcer disease, esophagitis, esophageal spasm can be confused with a ischemic heart disease. Sometimes it could be musculoskeletal, like patient when suddenly went for lots of gym and heavy lifting and ended up getting some strain in the chest muscle. That can be a cause. It could be a fractured rib. Costochondritis can be a cause as well. Okay, so we'll discuss all of them one by one. First of all, let's discuss about characteristic of each of the pain. So when you look at a question, the type and characteristic of the chest pain will give you a bit of idea that what can be the cause of this problem. Like if it is a coronary artery syndrome, or is it a stable or unstable angina, the chest pain will be, patient will say, I feel very tight in my left side of the chest. So tightness, heaviness, pressure feeling, this usually goes with cardiac chest pain. Sometimes this can be also associated with nausea, vomiting. Patient can be very sweaty. Patient can have palpitation and difficulty in breathing as well. So that's how a cardiac chest pain will feel like. If a patient complains of a sharp, knife-like stabbing chest pain, that goes more towards pericarditis. Okay, so sharp, knife-like chest pain is mainly goes with possibility of pericarditis. If a chest pain responds to nitroglycerin, it is most consistent with either it is an ischemic heart disease or it is an esophageal spasm. What if a chest pain gets worse with nitroglycerin? That sometimes occur with gastroesophageal reflux disease. So these are important clues. If a chest pain doesn't get any better with nitroglycerin, you would be thinking that, is it a cardiac pain or not? One of the important part of examining a patient who presents to you with a chest pain is, what do you really think this patient is having? Like, even by looking at the patient, you will get some idea of what's wrong. Like, if the patient looks very anxious, the patient has a fear of dying, patient is sweating in front of you, the pulse rate is very high, you would think that something sinister is happening. Okay? So those are a couple of important things to look at when you get such a patient. Now, in the note, we have written a lot of things about heart sound and murmur. This usually doesn't give us a lot of information, but you can definitely read it in your own time. But remember one thing, that everyone gets two heart sound, S1 and S2, and that is normal heart sound. But sometimes you can get a patient who has S3 gallop rhythm and a fourth heart sound. So both of them are abnormal. So if in your question it is written, patient has got S3 gallop rhythm, you'd be thinking possibility of a CCF. Same if there is a fourth heart sound, they can indicate angina or myocardial infarction. So these are important clues sometimes the question will have, and if you don't know it, you'll not be able to actually come to a diagnosis in the exam. So we are not going into any respiratory or any other chest pain, but we are mainly focusing on cardiac chest pain today. So let's say we have got a patient who is having this cardiac chest pain, and the pain is something like sudden onset of left-sided chest pain. The pain feels like crushing, pressure, or tightness. The pain radiates to the left arm, neck, and jaw. With that, patient having a like the associated nausea, vomiting, excessive sweating, and shortness of breath, you would be thinking about a likelihood of myocardial infarction. And the chest pain of myocardial infarction usually lasts more than 15 minutes. And it doesn't get fully better with nitroglycerin. Whereas if it is just a stable angina, in that case, the pain will be similar like what we have discussed, but the pain will last less than 15 minutes and it will get better with nitroglycerin. So that's one of the way to differentiate that, is it a stable angina or is it a full-blown myocardial infarction? All right. Now let's say we have got a patient who is having an acute onset of chest pain. What will be your next best management? What would you do next? Definitely an ECG. So ECG is always the first line investigation for someone having an acute onset of chest pain. And ECG, many times it cannot give us any information, but many times it can give us information, especially if it is a ST elevated MI. Okay, so most patients with myocardial infarction will have an abnormal initial ECG. So they will have ST elevation or pathological QOF. But patient who has stable or unstable angina, especially a stable angina patient, will have a normal ECG. Now, let's say, apart from ECG, what else we would do in a patient who can have a possible myocardial infarction? The next test that we do is cardiac enzyme. So the cardiac enzyme, we have CKMB, we have cardiac troponin, and previously people used to do myoglobin. So these are the three common cardiac enzyme that we can do. But nowadays we don't do myoglobin or CKMB very much. We'll be doing troponin. Troponin is our next best investigation if we don't get any ST elevated, if we don't get any ST elevation in the ECG. If you get ST elevation, you don't need to even look for troponin, because ST elevation in an acute chest pain, that gives you the diagnosis of ST elevated MI. But most of the time in a real life scenario, you would do a troponin in that patient as well. So troponin is the best cardiac enzyme that we would do nowadays. But still, you need to get just a little bit of idea about these cardiac enzymes. So have a look. Myoglobin will start to become abnormal in a patient with myocardial infarction in 1 to 4 hours. And the duration of abnormality will last only for 1 to 2 days. CKMB and troponin will start to rise in 4 to 6 hours. And the difference between these two is important. CKMB will only be elevated for 1 to 2 days, whereas troponin can be high for 10 to 14 days. Okay. Now the question comes in exams sometimes based on this duration. Let's say you have got a patient who has myocardial infarction, and then you have done a troponin, and troponin was significantly elevated. So you treated the patient as per the acute coronary syndrome pathway and guideline. That means you might have put, either you did a coronary bypass grafting or you have put a stent in the patient. So you have treated the patient. But after that, few days later, patient again started to get chest pain. Okay, so let's say that initial episode was 7 days ago. And then after 7 days, patient again started to get a chest pain. What will be your best cardiac enzyme in such a case? Troponin, myoglobin, or the CKMB? Because this is a reinfarction, and it can happen. It's not common, but yes, reinfarction happen. So if you think that this is a reinfarction and patient coming back within 10 to 14 days of initial raised troponin, then that will not give you a lot of information. So if it is a reinfarction and patient comes within 14 days of initial raised troponin, your best approach would be to doing this CKMB. Why? Because CKMB will be only elevated for 2 days. So now if the reinfarction happens, if CKMB is again high, that means you can confirm that yes, there is a reinfarction now. But troponin might be elevated still now. Okay, so that's why for reinfarction, we go for CKMB. Apart from reinfarction, like very, very unusual that nowadays we would do a CKMB. So it's troponin always. Okay, so this is from Kaplan Institute to CK. They talked a little bit about the CKMB cardiac troponin, so you can give it a read. Now, moving on from, so you have done an ECG, you have done a troponin, and sometimes if you think that there might be something else going on, such as a chest condition or like a lung condition causing the chest pain, then you can do chest X-ray. Chest X-ray can rule out pneumothorax, pneumonia, pleural effusion, those things. No, myoglobin is not done at all. Very unusual to do a myoglobin. You can do for reinfarction, but myoglobin very rarely done. So better to do a CKMB. Causes of chest pain. So we already got a bit of idea about causes. So we know about the characteristic of a ischemic heart disease or myocardial infarction, chest pain. How about some other causes? So let's say it's not myocardial infarction, but aortic dissection is your cause. The aortic dissection pain is retroesternal, sudden onset, extremely severe. So sharp, tearing, extremely severe, feels like someone is like just putting a knife into it. So it's a very sharp, extremely severe, sudden onset, tearing sensation, and most importantly, the pain will radiate to the back. So if you get such a patient who has this kind of retroesternal chest pain, sudden, severe, and feels like a sharp tearing radiating to the back, definitely you need to consider likelihood of aortic dissection. Okay, Now, aortic dissection, we will discuss in detail later on. For pulmonary embolism, we discussed pulmonary embolism in respiratory system in detail, very important topic. In pulmonary embolism, there will always be some risk factor. Maybe patient had a recent air travel for more than 12 hours and patient slept throughout the flight, ended up getting a DVT, and then from DVT, now patient has got a pulmonary embolism. Pulmonary embolism always has some, most of the time has some underlying risk. That means most of the time it is provoked. So a patient will come to you with a sudden onset of acute shortness of breath, chest pain, and if you also do a physical examination, you will get tachycardia, tachypnea, so heart rate and respiratory rate will be high, and oxygen saturation will go down, which is hypoxia. So risk factor and patient coming to you with sudden onset chest pain, shortness of breath, tachycardia, tachypnea, hypoxia, you would consider pulmonary embolism as one of your diagnoses. Pericarditis. Pericarditis, mostly it is preceded by a recent viral infection, and then patient comes to you with a sharp chest pain. Now the pain is very typical. So it's a sharp stabbing chest pain on the left side of the chest, and the pain gets better with leaning forward and worse with lying down. So that's the main important finding. So if a patient complains of a sharp left-sided chest pain and the pain gets better with leaning forward, worse with lying down, you would consider pericarditis as one of your diagnoses. So this is a table of all the important causes of chest pain that we have discussed so far. Okay, costochondritis. So you know about costochondral junction on the chest. Sometimes that costochondral junction can get strained or inflamed. How we know that that is the cause of chest pain? The best way to know that if a patient say that my chest is tender to touch, okay? So if the cardiac chest pain will not be tender to touch because it's coming from deep down, so from the heart itself. But if it is a costochondritis, it's a musculoskeletal problem. So patient will say it's tender to touch. So then you can think of costochondritis, okay? And we will talk about peptic ulcer, where peptic ulcer pain will be epigastric pain, not chest pain. So epigastric pain and pain get worse after eating, then you could think of peptic ulcer disease. Okay, so far we learned about the causes of chest pain, the characteristics of the chest pain, and the investigations related to it. Now we are moving into more important topic, which is ischemic heart disease. Are you guys all right so far? Any questions? Okay, so ischemic heart disease is a very, very important topic for your exam. So ischemic heart disease means coronary artery disease. And all of you know that coronary artery supplies your heart. And if that coronary artery gets blocked due to any reason, most of the time it is like excess fatty deposition or atherosclerotic plaque starting to develop, that's causing this blockage of the coronary artery. So symptomatic ischemic heart disease has been divided into stable angina and acute coronary syndrome, which has three types: unstable angina, non-ST elevated MI, and ST elevated MI. So let's talk about stable angina. So if you look over here, this is a cross section of a coronary artery. And a normal coronary artery should be totally patent. There should not be any blockage like this, right? In a stable angina patient, there will be atherosclerosis plaque starting to build in the coronary artery, but it's not fully blocking the coronary artery yet. So still there is enough blood supply. But what happens that whenever they do some exertional activity like walking, running, maybe going for some playing, then because during that time they require more oxygen, but their artery is blocked, so the body cannot supply enough oxygen during that time, they started to get the chest pain. So stable angina, the pain will be also same, left-sided chest pain. Pain will have all the characteristic, but the pain will be mainly with exertion. And when they take rest, the pain should get better. Pain should not last more than 15 minutes, and it should get better with glycerin spray or nitroglycerin. So that's a stable angina, okay? So symptoms is always with exertion. Then we have acute coronary syndrome where patient starts to get, sometimes the plaque can get ruptured and it can cause complete blockage as well. So that's the time you would think of unstable angina, non-ST elevated MI, and ST elevated MI. Now, the symptoms will be pretty much same for these three. It is the investigation which will lead us to think, is it unstable angina, non-ST elevated MI, or ST elevated MI? But the symptoms are same for this. So what is the symptom? Chest pain, which get worse with exertion, doesn't get better with taking rest, doesn't get fully better with nitroglycerin, and the pain lasts for more than 20 minutes as well. Okay? Now we will come back to stable angina, unstable angina just a bit later when we go to John Murtagh. Okay? So this is just a baseline idea that what is a stable angina, what is unstable, and what are the other things like non-ST and ST elevated MI. So major cardiovascular risk factor. So what are the risk factors that usually important for ischemic heart disease? So first of all, the single most important risk factor for ischemic heart disease is raised LDL cholesterol. So these questions come in exam. So they give you a patient who has high risk of cardiovascular event, and they ask you, what is the single most important risk for this patient to get a myocardial infarction? So single most important thing is raised LDL cholesterol. And sometimes also they ask, what is the worst risk factor in a patient with coronary artery disease? That's diabetes, because it causes more complication in a ischemic heart disease patient. And what is the most common risk factor? Hypertension. So three things. What is the single most important risk? LDL cholesterol. Worst is diabetes, and most common is hypertension. So try to remember like these three because it can get confusing in the exam. Let's do a question. A 48-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. She is comfortable now. The location of the pain is retroesternal. Pain sometimes associated with nausea. No shortness of breath. Pain doesn't radiate beyond the chest. No other past medical history. What will be the diagnosis? So if you look over here, it's a 48-year-old woman having a chest pain happening over several weeks, but not related to exertion. If a chest pain is not related to exertion, then it is unlikely to be a cardiac origin. Okay? So what else can be? Can it be a reflux, unstable angina, pericarditis, pneumothorax, Prinzmetal angina? You can easily come to the diagnosis that it is likely to be gastroesophageal reflux. Okay? How? Because unstable angina will not come over several weeks. Pericarditis, you know how the pain looks like. Pneumothorax, definitely not for several weeks. It will come acutely. Prinzmetal angina, again, there is some specific feature of it. We will discuss later on. So this is most likely just a reflux. And always remember that patient, especially women who is premenopausal, very rarely they get a heart attack. So you can see here, if a 48-year-old woman had a chest pain with no risk factor, it would be very unlikely that heart chest pain is related to ischemic heart disease. So menstruating women virtually never have myocardial infarction because the female estrogen actually protect them to have this kind of problem. But by the time they become menopausal, their risk becomes equal to men. So the question in here is, which of the following is the most dangerous to a patient in terms of risk factor for coronary artery disease? So we already know elevated triglyceride, elevated total cholesterol, decreased HDL, elevated LDL, and obesity. So among the option, elevated LDL is the most important risk factor and most dangerous one. We'll discuss about this, Dr. Sanjana. Give us few time, so we'll come to those angina when it is the time. Okay. Now there is a condition called Takotsubo cardiomyopathy. A postmenopausal woman develops chest pain immediately on hearing the news of her son's death in a war. She develops acute chest pain, dyspnea, ST elevation in V2, V4 on an ECG. Troponin elevated, and you confirmed acute MI. So you send the patient for a coronary angiogram, but there is nothing there. So coronary angiogram is a test which looks directly into the coronary artery for any blockage. So how come this patient has got raised troponin and ST elevation, but coronary angiogram is totally normal? So then you send the patient for an echocardiogram, and it found a classic finding, which is called ballooning of the left ventricle. So there is a condition called Takotsubo cardiomyopathy, where a patient gets, yes, it is broken heart syndrome, very good. So in which patient presents to you exactly similar like a ST elevated MI. But when you do an angiogram, you don't get any blockers. And that's the condition called Takotsubo. Now you might think that why I'm discussing this, it is very rare. Actually, it is not very rare. We have seen a lot of patients who get Takotsubo. So it's not very, very rare. It is not uncommon, especially in female. So Takotsubo is an acute myocardial damage, most often occurring in postmenopausal women, immediately following an overwhelming, emotionally stressful event. So it is a response to something really overwhelming for a patient, such as financial breakdown, earthquake, lightning strike, hypoglycemia, something which is very stressful for the patient, which will cause ballooning of the left ventricle, and left ventricle will not move as it should be, which will cause the dyskinesis of the left ventricle. Okay, so the problem is not inside the coronary artery, rather the left ventricle is not moving. So that's why there is not much of a blood supply happening. So patient usually presents with a similar features like a MI. So the only way to confirm the diagnosis is to do a coronary angiogram and the echocardiogram. So echo will give you the confirmatory diagnosis. So as with ischemic disease, managed with beta blocker and ACE inhibitor, but the main thing is that for coronary artery blockage, such as myocardial infarction, you would do revascularization. Either you put a stent in or you do a coronary bypass grafting. But in this patient, there is no block. So there is no need of any revascularization in this patient. Okay? So just remember that if they give you a questions where patient presented with all the features of ST elevated MI, but coronary angiogram is normal, that's the time you would think of Takotsubo cardiomyopathy. Okay? Correcting which of the following risk factor for coronary artery disease will result in the most immediate benefit for the patient. So although these questions are not pretty exciting, but sometimes these questions come in exam. So definitely, smoking cessation has the greatest immediate outcome in patient with a known coronary artery disease. So if you can stop smoking, you can reduce the risk of of having a heart attack. So within 2 years after stopping smoking, the risk is reduced by 90%, which is huge, right? Yes, so massive catecholamine or massive adrenaline release. Now, let's say you have got a patient who fulfills the criteria of acute myocardial infarction. That means the chest pain lasting for more than 20 minutes. So you did an ECG, and in the ECG, two things can be there. One, patient has got ST elevation. That means you can diagnose it is ST elevated MI. But when there is no ST elevation, that's the time you would be confused. So when there is no ST elevation, it is either unstable angina or it is non-ST elevated MI, right? So how we can differentiate between unstable angina versus non-ST elevated MI? What do you think, guys? So the main difference is that in non-ST elevated MI, your troponin will be elevated. So that's the only way to differentiate between these two. Okay, the pathophysiology, everything is same. The symptoms, everything is same. The only way to differentiate between these two is to do a troponin or cardiac enzyme. So if cardiac enzyme is normal, that's unstable angina. If cardiac enzyme is elevated, that's non-ST elevated MI. So therefore, in establishing the diagnosis of non-ST elevated MI, cardiac troponin should be used to distinguish from unstable angina. Okay? Now, why it is important to know that is it unstable, is it non-ST elevated, is it ST elevated? There is importance why we give a lot of emphasis on it. Because in ST elevated MI, the patient will get like a full blockage. There is no blood flow at all, which is full thickness coronary block. In such a condition, because blood cannot pass to the distal, like blood cannot pass distal to the blockage, there can be irreversible necrosis or damage. So for that patient, revascularization is indicated. So ST elevated MI patient will need thrombolytic therapy. And the thrombolytic therapy can be anything, can be percutaneous coronary intervention, such as a stenting, can be just a medication to dissolve the clot, right? Like alteplase, retiplase, streptokinase. But thrombolytic therapy is only indicated for ST elevated MI. It is not indicated for unstable angina or non-ST elevated MI. Okay, so this important difference usually help us to guide the management for the patient. Okay, so if we look over here, that in a ischemic cardiac chest pain, stable angina, according to JM, it is 20 minutes. According to Kaplan Step-to-CK, it is 10 minutes. Now, we have a less tolerance about cardiac chest pain. So even sometimes if a patient has high risk factor, such as a smoker, previous history, family history of heart condition, high cholesterol, diabetic patient, for that kind of patient, even if the chest pain goes above 10 minutes, we will start following the acute coronary syndrome pathway. Okay, but as part of John Murtagh 8th edition, they say after 20 minutes, you can go for a stable angina. After 20 minutes, acute coronary syndrome. But as part of the exam, I would still be happy to keep it 10 minutes, especially for someone who has high risk. We know about like what are the quality of the chest pain, the associated symptoms and everything. So let's not go into that. Now, let's say Now we are going a little bit deeper part of the cardiac imaging and cardiac investigation. So let's first talk about stable angina a little bit, and then we will move on to myocardial infarction. So let's say you have got a patient who has a stable angina. That means the chest pain only comes with exertion, gets better with rest, doesn't last more than 10 minutes. For a stable angina patient, the idea is to find out that if this patient will be benefited from an elective stenting or reperfusion therapy. Okay? So for a stable angina patient, if you do a ECG, especially when they are rest, you would not get any baseline ECG abnormality most of the time. Okay? Because it only happens when they are exertional. So when they are running, walking, then. So what we want to do is that we want to make them stressed, or we want to do them exercise and then check the ECG while they are doing the exercise, like running on a treadmill. There comes your stress test or exercise tolerance test. So you must have heard about a stress test or exercise tolerance test. So this is mainly for a stable angina patient. So let's say you have got a stable angina patient and your baseline ECG you have done. In the baseline ECG, you didn't find anything really bad. Okay. For those patients, if you can read the ECG, and if your patient is able to exercise, like they haven't got a very bad knee because of severe osteoarthritis, so they can run on a treadmill, for that patient, a stress test will be the next step of management. Okay. So first of all, there is no baseline ECG abnormality and patient can exercise. Then for a stable angina patient, you'd go for exercise tolerance test where patient will run on a treadmill and patient will be hooked on a machine with an ECG monitor, and we'll be checking for when patient is running if there is any ECG changes happening or not. Okay, so that will give us an idea of inducible ischemia. That means we are inducing ischemia in the patient by asking him to run on a treadmill. What if your patient is unable to exercise, or there is already some baseline ECG abnormality, like there is left bundle branch block, left ventricular hypertrophy, patient already on a pacemaker, or patient is on digoxin. So if there is a baseline ECG abnormality, then you can't just do an exercise tolerance test. So for someone who has got a baseline ECG abnormality, our best method of detecting ischemia is doing some nuclear scan. So you can either do a nuclear isotope scan, which is thallium scan, or you can do an echocardiogram, and echo can show that some part of the cardiac wall is not moving as it should be. So you get regional wall motion abnormality, commonly known as RWMA. Again, your patient is able to exercise, your patient doesn't have any baseline ECG problem. In a stable angina patient, you would do the ETT. But there is a baseline ECG problem, then your next step to find out if the patient having any ischemia is to do either a thallium scan or a nuclear scan, or you do an echocardiogram. So what we actually find out in the nuclear thallium scan, so you insert a dye and this nuclear isotope, such as now you're giving the thallium isotope, your cardiac muscle, so the cardiac muscle which is well perfused and getting reasonable amount of blood supply from coronary artery, there will be in like homogeneous uptake of this nuclear isotope. Again, so if your cardiac or if your heart is getting blood supply, then this this dye or isotope will move or will be absorbed by the cardiac muscle everywhere. Now let's say this coronary artery is having a bit of block. So this part of the cardiac muscle, which is supplied by this artery, it will not have that much of a nuclear scan uptake. So there will be reduced uptake here. That's the time you would get an idea that maybe patient has got a block in this area. That's why this part of the cardiac muscle did not uptake enough isotope. Okay, so abnormality will be detected by seeing decreased thallium uptake. And in case of echocardiogram, you will be just looking by a echocardiogram that if all the walls of the heart is moving as it should be. If let's say the left ventricular wall is not moving, that means maybe this part of the heart is not getting enough blood supply. That's why it's not moving. Okay, so the idea is if patient cannot access, if patient is having a baseline ECG abnormality, you would either do a nuclear thallium scan or you do a echocardiogram. Does it make sense so far? It's a bit difficult, but I'm sure you will understand it. Okay, what if the patient cannot exercise? So if your patient cannot exercise, then you need to make the heart as if it is exercising. So how we can do that? So in that time, you can either do a nuclear thallium scan plus giving a chemical which will increase the heart myocardial oxygen consumption. Again, for patient who cannot exercise, for them, you need to make the heart running so that it works like exactly the same way for someone who is actually running on a treadmill. Okay, so let's say your patient is unable to run on a treadmill. So you would give a chemical which will give the same effect as if the patient is actually doing an exercise. So you give adenosine and then you do a nuclear scan, or you give dobutamine and then you do an echocardiogram. So this adenosine, dobutamine, these will increase the myocardial oxygen consumption. Okay, so now let's come to the summary of all these tests that we can do for someone who has got a stable angina. So first of all, your patient does not have any, so no baseline ECG problem, and patient is able to exercise. For that patient, you would do exercise tolerance test. Your patient has got a baseline ECG problem, but still patient can exercise. Okay, so in that case, you would do an exercise thallium scan. So patient will exercise while you have given a dye or nuclear uptake or nuclear thallium to the patient. Okay, either you can do the exercise thallium or you can do the exercise echocardiogram. Okay, so your patient does have ECG problem. That's why you are going for exercise-induced thallium or exercise-induced echo. All right, but let's say your patient cannot exercise. In that case, you would go for chemical thallium scan or chemical echocardiogram. And those chemicals for echo, we use dobutamine. For thallium, we use dipyridamole. Does it make sense, guys, now? Okay, very good. So this is one of the most confusing one. Sometimes questions come in the exam and they give you like patient can exercise, or they give you patient cannot exercise, patient has baseline left bundle branch block. So in those situations, what would be your test? So this is how you can come to a conclusion that what kind of test you want to do. So what is the purpose of doing all of this? Yes, that's right, Dr. Nahir. So dipyridamole is used as an alternative to exercise. Because patient cannot exercise, you are giving dipyridamole to make the exact effect as if patient is actually exercising. No, we don't use both dipyridamole or adenosine in a same patient because it will provoke lots of problem. So use only one. So thallium scan usually goes more with adenosine and dipyridamole goes with echo. So what is the reason? Like why really we want to do all of this? There is a reason of this, right? So the reason behind it that in a stable angina patient, you want to know that if there is significant block or significant risk for this patient to end up getting a major heart attack. So that's why you're really doing all of this. So you found a patient with a stable angina symptom, then you send the patient for any of these tests. Let's say you did an exercise tolerance test. And the exercise tolerance test find out that patient has got ECG abnormalities during exercise. That will give you the diagnosis that yes, this is definitely a patient who has ischemic heart disease. So once you confirmed ischemic heart disease, your next step is to find out how much blockage is there. So to find out how much blockage is there, you do the coronary angiogram. Okay, nowadays we can do CT coronary angiogram, which is non-invasive. The invasive one is where you insert a catheter through the groin artery, and then you goes into the coronary artery, looks directly into the coronary artery, which is still done usually prior to surgery or prior to putting a stent, but that's invasive coronary angiogram. But nowadays, for a stable angina patient like this, you would go for a CT coronary angiogram. Okay, where patient will be given a contrast, and that contrast will find out how much blockage is there in each of the coronary arteries. Okay, if there is a significant blockage, then you can actually do a elective stenting in that patient, which can prevent for this patient to have a major heart attack in the future. That's the main reason why we are doing all of these tests. So you have got a man with atypical chest pain, found to have a normal nuclear isotope uptake in his myocardium at rest. So you have got a patient with chest pain because you are not sure that is it cardiac, non-cardiac. So send the patient for a nuclear scan, and at rest, there was nothing abnormal. Then you did the thallium scan when patient was exercising, and you found that there is decreased uptake of the isotope in the inferior wall. Okay. 2 hours after exercise, so patient did a rest, you again did the scan, and it came back to normal. So what does it mean? It confirms the diagnosis that you thought of. So you thought of a stable angina, and it has confirmed that this patient has got an inducible ischemia, which means when this patient exercises, the blood flow decreases, and it causes lack of blood supply to the heart muscle, right? So what would you do next? So in this patient, after that, you would do a coronary angiogram, because coronary angiogram will find out that if this patient has got like a significant block. By significant block, we mean more than 70% stenosis, in any of the coronary artery. So coronary angiography determines if this patient will require a bypass surgery or just a stent, such as angioplasty. So angiography is used to detect the anatomical location of the coronary artery disease, and also it can define that how much blockage it is and if this patient will require any intervention. Now, this will give you the guideline that all the things that we have discussed so far. So let's say you have got a patient with chest pain and you think that this is a cardiac chest pain. So you did a resting ECG and resting ECG was fine. Okay. So because it is now you're thinking it is a cardiac pain and patient doesn't have any baseline ECG abnormality, patient is also able to exercise. So you send the patient to a stress test, right? And let's say resting ECG was normal, but patient is unable to exercise. Then you do the chemical stress test, which is your dipyridamole thallium or dobutamine echo. I'm sure now you're getting the hang of it, right? So if patient cannot exercise, you do the chemical stress test. When there is baseline ECG abnormality, but patient still can exercise, then you do exercise thallium or exercise echo. Okay, exercise echo is also called stress echo. If any of this comes back positive, then you send the patient for angiogram. In the angiogram, if the patient has got significant blockage, which means more than 70% blockage in one or two vessels, that patient will go for angioplasty, which is a stent. If it is three vessel disease, then that patient will go for coronary artery bypass grafting. Okay, does it make sense for everyone? No, these chemicals are given in a way that it doesn't cause a heart attack. So your patients are stable patient. So you don't do it in a patient who is having a very severe chest pain. You do it in a patient who has a stable symptom. So these stress tests will not going to do any harm. But definitely we can't be sure. So that's why all of this. So is your patient able to exercise? Is your patient has any ECG problem? So we get the best test, which will be best suitable for or best appropriate for the patient. So it is not harmful for the patient. It is important for us to diagnose this patient so that patient doesn't end up dying from a heart attack. Okay, time to time, you will see in the option, they're talking about Holter monitoring. So what is this Holter monitor? Holter monitor is a continuous ECG monitor for 24 to 48 hours, where it can detect if there is any underlying rhythm disturbance. So many times patient will come to you with, especially elderly patient comes to you with feeling dizzy or lightheaded. And you did an ECG, you can't find out anything. You did everything, you can't find out any abnormality. So you want to know if there is any baseline rhythm disturbance that you can't find out at the moment. So you do a 48 hours ambulatory ECG monitor. That means patient will be doing everything that he normally does, but the ECG monitor will try to pick up any abnormal rhythm throughout these 2 days. So remember, Holter monitor is done for any underlying arrhythmia, not for any kind of ischemia. So you would not do a Holter monitor in a patient who has chest pain because you can't find out any cause of chest pain by Holter monitor. Okay. Now we are moving on to myocardial infarction discussion. So you've got a 48-year-old woman comes to the office with chest pain, that has been occurring over the several weeks. Pain is not reliably related to exertion. She's comfortable. Location of the pain is retrosternal. Everything is normal. What's your most appropriate next step? Now, this is that same question that we have done previously. And we know that this patient most likely got GORD, like gastroesophageal reflux. But in your option, they want you to do something. Okay, so they don't actually want you to just send the patient by saying it is GORD. So out of all these options, in this patient, what would you do? And Dr. Nahrir, so are we going to do a stress echo even if we find ECG abnormality? The question is, your ECG abnormality is not that ECG abnormality that we look for in a cardiac chest pain. Having a left ventricular hypertrophy, having pacemaker, having, let's say, uh, left bundle branch block does not make the patient to have ischemic heart disease. A ischemic heart disease patient will get T inversion, ST segment depression. That you are not getting. That's why you're doing the stress echo. And you want to find out when patient do the stress echo or the thallium scan if this is happening or not. Okay? So baseline abnormality means that something else, not cardiac, not ischemic ECG changes. Okay? Okay, so for this patient having a chest pain occurring over the several weeks, ECG is normal at the moment. So pain is not also related to exertion. Do we really need to do a troponin in this patient or CKMB? This is going on over weeks. So definitely this is not going to do anything. So for something like this, the best option would be to go for exercise tolerance test. So this patient is mainly having a chest pain occurring over several weeks. So if we really want to know that patient might have some cardiac chest pain, the only way to do it is to just get a stress test. Okay, because it is going on for several weeks. So doing a troponin is not really needed. Now, we'll discuss a little bit more about how we manage a patient who might have acute myocardial infarction. Okay, are you guys still with me? You guys not feeling like overwhelmed or anything like that? Good question, Dr. Simran. I don't like to do any test in this patient, but the problem is you have to choose an option in the exam. Sometimes you will end up in the exam that they're asking about something which really doesn't have any answer to do. Like this question, definitely I don't want to do any investigation in this patient, but you have to choose one option. In that case, what would you choose? Okay. So in a real life scenario, I would not really bother with the exercise tolerance test if it is not related to exertion. So again, sometimes you don't like the question, but in exam, you have to choose one option to go to the next question. So this is something like that. Why we do exercise tolerance test, Dr. Asma? After all this discussion, why we really want to do a stress test in any patient? What's the reason? Yes. So we want to exclude if the patient actually get any kind of ECG changes when she is running on a treadmill. Okay, this will give her a reassurance that no, it is not a cardiac chest pain. Sometimes you will get this kind of patient, like you reassure them a lot that no, it is not cardiac pain, but they would not actually be reassured until you do a test. So this is something like that. You send the patient for a stress test, it comes normal, you can reassure, and patient will be confirmed that no, nothing is bad. Okay, don't get too stressed about that question. Moving on. So when a patient gets acute myocardial infarction like chest pain, what we normally do? So there is a vast discussion about myocardial infarction management. Always remember, if your patient has acute coronary syndrome, your first and foremost management, so after you do the ECG and everything, is to start the patient with aspirin. So aspirin is one of the most important medication which has survival benefit. So aspirin is recommended in all patients who has acute coronary syndrome. High-risk patients should be treated with aggressive medical management, and arrangement should be made for coronary angiography and possible revascularization. So if you suspect the patient might have myocardial infarction, you looked into the ECG, there was no ST elevation, you did the troponin, okay, you found there is some abnormality. So if your patient having acute coronary syndrome, first you give the aspirin and you start the patient with treatment. And what kind of treatment? That's what we are going to discuss now. Okay. Any patient who comes to us with features of ACS, we start the patient with monotherapy. Among the monotherapy, aspirin is the main one. The others are not the most important. Like we have morphine. So morphine is mainly for pain. So if the patient is complaining severe chest pain, you would give them morphine. You give oxygen if the oxygen saturation goes down below 95%. You give nitroglycerin if even with morphine, patient complaining chest pain. And the nitroglycerin will be given as a nitroglycerin spray under the tongue. Now, out of all of this, aspirin is the most important, and it is the only one which has survival benefit. Okay? So the questions in the exam can get quite tricky. So I want you to understand what's the most important thing in a coronary syndrome patient. As soon as you start the patient with aspirin, you have to call the catheter lab for arranging a coronary angiogram plus reperfusion. Okay? So you would not wait for morphine, oxygen, nitroglycerin, and then call the catheter lab. You start aspirin, and then you call the catheter lab. Now, this is the management for ST elevated MI, not non-ST elevated or unstable angina. Okay? So you're talking mainly about ST elevated MI now. So you give the patient aspirin unless it is contraindicated and call the catheter lab, make sure it is ready. Idea is within 60 to 90 minutes of ST elevated MI patient entering into your hospital, you should be able to take the patient to the catheter lab. Okay, so optimal is 60 minutes, but highest 90 minutes. So within 90 minutes, patient needs to be in the catheter lab if that patient has got a ST elevated MI. Okay. Now we'll come to the further discussion, but for this question, a 70-year-old woman comes to the emergency room with a crushing substernal chest pain for the last hour. The ECG shows ST segment elevation from V2 to V4. What is the most appropriate next step in the management of this patient? So what would you choose? Now remember, in your exam, you will not get this much option, only 5 options. But what do you think you would do in such a patient? Aspirin, definitely. Okay, so that we know. 90 minutes from the admission, not from the onset of chest pain. That's a different thing. We are coming into that. So aspirin lowers the mortality with acute coronary syndrome, and it is critical to administer it as rapidly as possible. Patient had the chest pain just for 1 hour. Will you get anything positive like CKMB, troponin? Anything will be positive in this patient? No, because for troponin to be higher, at least 4 to 6 hours is needed. So doing a troponin or CKMB in this patient might not even give you anything. Okay? Morphine, oxygen, nitroglycerin should all be administered, but they do not lower mortality, and they are not as important as aspirin. Aspirin should be given simultaneously with activating the catheter lab. This is where candidates get it wrong. They think that they will give aspirin, then the morphine, then oxygen. After everything, they will contact the catheter lab. Okay? Now there comes your second question. You have got the same patient who has chest pain, ST elevation, and you have given aspirin. What is your most appropriate next step in the management of this patient? Now, let's see what you think about it. You want to give, you want to do a CKMB, oxygen, nitroglycerin, morphine, thrombolytics, metoprolol, statin, angioplasty, troponin, or lisinopril. Yes, definitely angioplasty. If you can do angioplasty in a tertiary hospital, your first step is angioplasty. Thrombolytics, yes, we do. There are options. So angioplasty or percutaneous coronary intervention is your first step. If you can't do angioplasty, like let's say you're in a rural hospital and you don't have any angioplasty equipment or anything, you don't have a catheter lab in your hospital, in that case, you can do thrombolytics. Okay? Remember one thing, there are two different things. One is that 60 to 90 minute. 60 to 90 minute is from the time patient enter into your hospital, and that's a ST elevated MI patient, they are supposed to be in a catheter lab to have the PCI. If you can't do that, better to go for thrombolytics. Okay? Now, thrombolytics or angioplasty, it is usually indicated if patient comes within 12 hours of onset of symptom. So this is where candidates also get confused because it is quite confusing in the John Mottag as well. So either angioplasty or thrombolytics can be done if patient comes within 12 hours of symptom onset. That means 12 hours of chest pain. After 12 hours, doing this reperfusion usually doesn't give us any better outcome. We would still do it, but it doesn't give us best outcome anymore. Okay? And if you have catheter lab, if you have the opportunity to do the angioplasty, then you do the angioplasty. But if your hospital doesn't have a catheter lab, or you can't do the angioplasty within 90 minutes, better not to delay, just go for the thrombolytics. Because angioplasty is the best option, Dr. Shabir. Okay, thrombolytics has a lot of risk. Is it clear for everyone so far? So within 12 hours of cardiac chest pain, you can either go for angioplasty or thrombolytics. But between angioplasty and thrombolytics, definitely angioplasty is the best approach. If your hospital doesn't have catheter lab, you're in a rural hospital, then thrombolytics can be done. But both of them are within 12 hours of symptom onset. The 60 to 90 minutes is mainly for a patient who who enters into your hospital, they usually should be into the catheter lab within 90 minutes. Okay, 90 minutes of enter into your hospital, not from the symptom onset. So angioplasty is associated with greatest mortality benefit of all the steps listed in this question. Now, let's see another question. A man comes to the ED with a chest pain for the last 1 hour that is crushing in quality, does not change with respiration or position. ECG shows ST segment depression, not elevation. Aspirin has been given. What is the most appropriate next step in the management of this patient? Low molecular weight heparin, thrombolytics, then at abiciximab, nitroglycerin, morphine, angioplasty, metoprolol. So this we haven't discussed yet. For ST elevated MI, after aspirin, you involve the catheter lab for angioplasty. Remember, I think at the initial part of this class, we discussed that reperfusion is not needed for non-ST elevated MI or unstable angina. So someone who has got ST depression, it is either an unstable angina or non-ST elevated MI. We still don't know because we can't, like troponin will not give us any information in here because it's just for 1 hour. So what would you do? For such patient who has like either non-ST elevated or unstable angina, best management is low molecular weight heparin after aspirin. For them, thrombolytics, then angioplasty has no benefit. And Dr. Irosha, if ST elevated MI present after 12 hours, angioplasty or thrombolytics, first choice. For such patient, it is no longer a PCI or something like that. So even after 12 hours, what would you do is you would still organize a coronary angiogram for that patient to see if you can go for a stenting. So you can still do that, but it is not going to be as fast and as urgent like the other one. Like if patient comes within 12 hours, you have to do everything within 60 minutes. But for someone who presents after 12 hours, you don't need to do anything urgently anymore. Okay, so still, if you have angioplasty option, you would still consider that as the best option. Okay, so this is for unstable angina or non-ST elevated MI, your best option will be heparin. So heparin will prevent a clot from forming in the coronary artery. It does not dissolve the clot that has already formed. When the patient has acute coronary syndrome and there is no ST segment elevation, there is no benefit of thrombolytic therapy. Okay, so that's your main thing that you should remember from what we have discussed so far is that if it is a ST elevated MI, first aspirin followed by angioplasty, like angioplasty or thrombolytics. Non-ST elevated MI or unstable angina, after aspirin, we go for low molecular weight heparin. Okay. Now, even for patient who has non-ST elevated MI, you would do coronary angiogram, but it will be within 48 hours. So now it is no longer like as urgent as it is in a ST elevated MI who presents within 12 hours. Okay, so even for non-ST elevated MI, you would do the angiogram because you want to find out like how much blockage is there and if the patient can be benefited from a stenting or a bypass surgery. So that's the main approach is that how fast you need to do the process. Okay, and what's your step-by-step management? All right, so even with a non-ST elevated patient, we still do angiogram. We still might need to do like either a CABG or a stenting, but it will be done within 48 hours. Okay. For kidney disease, unfractionated heparin. Okay. So these are like from your Kaplan strip to CK. And you can see what we have discussed so far. So patient with ST elevated MI who presents within 12 hours of the onset of symptom should have a reperfusion strategy, which is basically by percutaneous coronary intervention, which is a stenting, or fibrinolytic therapy, which is those streptokinase, alteplase, reteplase, those things. Patient with non-ST elevated MI will not benefit from thrombolytics. Okay, now we were discussing about some of the patient might require fibrinolytic therapy, especially for patient who cannot have stenting. For those patients, we need to go for fibrinolytic therapy, right? Like the streptokinase or alteplase. So before we give that, we always need to make sure that if that patient has any contraindication to fibrinolytic therapy. The absolute contraindications are patient having any active bleeding disorder, significant facial trauma or head injury within 3 months, suspected aortic dissection, previous history of hemorrhagic stroke or intracranial hemorrhage, and within the last 3 months, patient had a ischemic stroke. For this kind of patient, you can't consider fibrinolytic therapy anymore. So there comes your question. So you are asking about if someone presents after 12 hours, like late presentation. So see what we normally do for that patient. Reperfusion therapy with either PCI or fibrinolysis is not routinely recommended in patients who are asymptomatic and hemodynamically stable and who present after 12 hours of symptom onset. So for those patients, it's no longer called as a reperfusion strategy. For those patients, ideally you would go for, like, first you send the patient for angiogram. An angiogram will find out how much blockage it is, and then it will decide if that patient will require a CABG or a stent. Okay, any questions so far, guys? Is it making sense? Now, when we go through John Mottag at the end, we will go for like a revision of everything that we discussed, and it will make a like the best solution of your questions if you have any. So some of the risk factors after having a myocardial infarction management. So let's say you managed a patient with MI. You done the reperfusion therapy. What could be the complications after that? One of the common complications that it can be that patient can get mitral regurgitation. They can get a post-infarct angina, like you have treated the patient with a stenting, but they again got infarction. Any post-infarct angina after PCI or thrombolytic should be treated by bypass. Sometimes patient can get post-MI pericarditis, which is called Dressler syndrome. And the most common cause of death after a MI is ventricular fibrillation. So sometimes this kind of question just pop up in the exam. We were talking about Prinzmetal angina, right? Dr. Sana, so what should we do if a ST elevated MI patient presents after 12 hours and is not suitable for angiography either? Why patient will not be suitable? That's the question. Angiogram can be done in any patient. Okay, I'll give you time to answer that, Dr. Sana. So Prinzmetal angina or variant angina is a very uncommon condition in which episodes of severe angina are triggered when one of the major coronary arteries suddenly goes into spasm. So Prinzmetal angina or variant angina is nothing but sudden coronary artery spasm. So if coronary artery normally like this, and they go into a spasm like this, so definitely there will be like vasoconstriction and the blood supply will be less. That's the time sometimes patient can also get a ST segment elevation on the ECG. As opposed to typical angina, Prinzmetal angina usually occur during period of rest, most often at night and in the early morning hours. So definitely if a patient getting like frequent chest pain, you can send the patient for exercise test that will come normal. Still patient having ongoing chest pain, you ended up sending the patient for coronary angiogram, still it is normal. That means then you can rule out that it is not a coronary artery block or atherosclerosis. And in your head, you are thinking that is this can be a Takotsubo? So you did an echocardiogram, still nothing. Then you thought like, well, maybe it is a variant angina. So then you can do a argonovin test. So argonovin is a trigger which causes coronary artery spasm. So if you give argonovin and then you see if the patient has got the chest pain and again ST elevation, that will confirm the diagnosis of Prinzmetal angina. Because it is caused by coronary spasm, you can give something which can dilate the coronary artery. So what are dilators? Calcium channel blockers. So calcium channel blocker or nitrate will be the treatment of choice in this patient. Does it make sense? So it depends, Dr. Sana. So many times we always find out that if the patient can go for angiogram or not. So if the patient has got acute heart failure, definitely you'll treat the heart failure first. You make the patient stable, and then you go for angiogram. So those are like a different scenario. Those scenarios are mainly for a specialist. You as a junior doctor, you will not be treating such a patient anyway. And that is usually not expected in the AMC exam. Okay. Do you guys need a break or can we continue? Continue? Okay, let's continue. So moving on to aortic dissection. So aortic dissection is a sudden onset of retrosternal chest pain, which goes to the back and it has a tearing, ripping sensation. Sometimes the pain can radiate to the abdomen, flank, or legs. Okay, the type of the pain will give you the idea that it might be a case of aortic dissection. So if you suspect a patient to have dissection, first, any chest pain, you would do an ECG. You will not get any positive finding. Then you can do even a chest X-ray. Chest X-ray sometimes shows widening of the mediastinum. We will show you when we do the imaging. If you suspect that, well, this is likely to be a dissection, your best test is transesophageal echocardiogram. But sometimes doing a TOE, it requires general anesthesia. Okay? So that's why sometimes it is difficult to arrange a transesophageal echo immediately. So what else can we do is we can do a CT angiogram. Okay? And CT angiogram will be able to confirm that if it is an aortic dissection or not. But as part of the exam purpose, if exam give you a scenario of aortic dissection, and they ask for the best investigation or definitive investigation, then you would do a transesophageal echocardiogram. Okay. So how we treat aortic dissection? Aortic dissection is treated depending on the type of dissection. Okay. So the type of dissection is, let me draw a picture for you. Now, you know about the aorta, and then the aorta has these branches. So brachiocephalic, they've got the carotid and subclavian, right? So that's the left subclavian artery. So dissection means the tear in this aortic muscle. So if there is a tear happens proximal to the subclavian artery, so anything in this area, that will be called as type A aortic dissection. And any dissection distal to this left subclavian artery is called type B. Which one is worst? Type A, definitely, because it is close to the heart. So type A, you need to go for emergency surgery, and chance of dying is really high. So it is difficult to treat this kind of patient. But for type B, your main management will be first controlling the blood pressure, because 50% patient with type B dissection will be very hypertensive. Okay, so for type B, your first management is to control the blood pressure. So ideally, you give a IV beta blocker, which is IV labetalol. So that's your first line medication. And then if it's still hypertensive, you can give IV nitroprusside. And after that, if you want, you can go for repair. But first line management for type B is always antihypertensive. Okay, any questions so far? So we would not discuss the pulmonary embolism in cardiac class. We will discuss in our respiratory system. Okay, so that finished the note that we have for you. But now we will go through a little bit from John Murtagh. So John Murtagh, chapter 30 is your chest pain chapter. Okay, then we discussed most of the thing that is written in John Murtagh anyway, but I'll just go through a few things that is not in the note so that you can also correlate. So have a look on here. The type of the chest pain for heart condition is pressure, heaviness, or tightness. Associated symptom we already discussed. If a retrosternal chest pain is precipitated not by exertion, but by bending, lifting, straining, or lying down, consider esophageal reflux. So that is an important clue that if there is a pain which is retrosternal, but the pain is not related to exertion, but bending, lying, it is likely to be a gastroesophageal reflux. Stable angina. So a stable angina lasts for very, very few minutes. So sometimes 3 to 5 minutes. So this time varies. So some books write 10 minutes, some book write 20 minutes, some book write 5 minutes. So this varies a lot. So As part of all the guideline, we can still keep a stable angina up to 10 minutes. Okay, but JM 8th edition has now reduced it to 5 minutes. But the thing is that it always depends on a lot of other comorbidities patient has. So we have low tolerance in a patient who has more risk. We have high tolerance for patient who has less risk. Okay, so as part of JM, stable angina is the same chest pain that we discussed, but lasts for 5 minutes and relieved by rest and GTN. Whereas myocardial infarction is the pain that lasts longer than 15 to 20 minutes, heavy crushing chest pain. Now, can a myocardial infarction patient still has MI, but no chest pain? Yes. Painless chest pain can happen, especially with a diabetic patient. Okay. Unstable angina. So patient with unstable angina, still their pain can last 15 to 20 minutes. But again, we can only differentiate unstable angina, the non-ST elevated MI and ST elevated MI based on the ECG finding and the cardiac enzymes. So let's say, as we are discussing the pericarditis, so pericarditis is a sharp stabbing pain, as we know, that which gets better with leaning forward and worse with lying down. Most common is virus, sometimes could be a connective tissue disorder, or even can be after a myocardial infarction. So in patient with pericarditis, there is a specific ECG finding that we get where you get widespread ST elevation in almost all leads, which we will discuss in our ECG class. You can always get a pericardial friction rub in this patient. Okay. Some of the other type of pain that we get in this patient is the pain which get worse after coughing or having a deep inspiration, which is pleuritic chest pain. Sometimes pain can be brought on by swallowing. So these are all important clues. Some patients can have steady crushing retrosternal chest pain, which mimics myocardial infarction also. Okay, but the most common symptom is the one that is retrosternal, aggravated by coughing, deep inspiration, and worse with lying flat, relieved by sitting up and leaning forward. The cardinal sign is pericardial friction rub, but sometimes you don't get it. The treatment for patient who has pericarditis is colchicine for 3 months, plus aspirin or ibuprofen for 1 to 2 weeks. So remember the management because it can come in your exam. No, the definitive, so I don't know what's your name, iPhone 13. So the definitive investigation is TOE, that's for sure. But investigation of choice, you can still say CT angiogram or CT aortogram, same thing. So because as I said, that TOE is difficult to get immediately. So if they are asking that what is your next most appropriate investigation or what is your investigation of choice, then yes, you can still do the CT aortogram or angiogram because it is readily available and you need to get the diagnosis. But if they ask the definitive test, best test, that is definitely TOE. Pneumothorax we will discuss in respiratory class. Angina. So we talked a lot today about stable angina. So you can already understand what are the symptoms and everything. They also give you some of the variation of stable, unstable angina, which we discussed, like Prinzmetal angina. ECG is not for today. So this is where they discuss about exercise ECG, exercise thallium scan, Holter monitor. So all of these are discussed in our today's discussion. This is how the coronary angiogram is done. Management. So how we manage a stable angina patient. So that's what we didn't discuss today. So definitely lifestyle modification, always the important part. Apart from lifestyle modification for a stable angina patient, there are some medical treatment that can be done. Like you can put the patient on nitrate, so either nitrate sublingually, or there are tablets like isosorbide mononitrate or dinitrate. So nitrate is one of the common medication. Put the patient on aspirin. If patient is not tolerating nitrate, then also sometimes we can give nifedipine. Okay. So for mild angina or patient who gets episodic angina, the best treatment, so someone who has acute angina, like they're actually getting the chest pain now, the best management is glycerol trinitrate, which is a spray under the tongue. That's for acute attack. Now, to prevent further progression of angina, sometimes you can start patient with some medication which is cardioprotective. For cardioprotection, you add aspirin. You will give a beta blocker, so either atenolol, metoprolol, and you add a regular daily dose of nitrate. Okay, so for patient who gets angina, mainly with some moderate exertion, these three medication is must to add: aspirin, beta blocker, nitrate. For someone on the top of beta blocker is still getting angina, then you add a calcium channel blocker such as nifedipine or amlodipine. Okay, so mainly in the exam, if they give you a stable angina patient, they will ask you, what is your best preventative medication? The best preventative medication for patient who has like a moderate stable angina is aspirin. That's the first thing, then the beta blocker, and then the nitrate. If the question asks, what is the best treatment for acute angina? That's nitrate. All right, so these are all the things that we discussed. This is where they discuss about the myocardial infarction. So aspirin as soon as possible. Management of ST elevated AMI. So the optimum first line treatment for patient with ST elevated AMI is urgent referral to a coronary catheter lab, ideally within 60 minutes of the onset of pain for assessment after coronary angiography for percutaneous, like that means angioplasty. So within 60 minutes, patient usually needs to go for an angioplasty. So urgent reperfusion guideline. Within 60 minutes, patient ideally should have a PCI. If these targets are not reached, now in here, the John Murtagh has made a bit of confusion by saying symptom onset, but it is actually not the symptom onset because there will be a lot of patients who can't actually come in the hospital within an hour of chest pain. That doesn't mean that you would not take the patient for a catheter lab. Okay, so it is actually not symptom onset, but the 60 minutes is mainly when the patient enters into your hospital. Okay, so please don't get confused by this line. So if the targets are not reached, then fibrinolytic can be given. For patients presenting after 12 hours, you can still consider reperfusion if patient having these features: continuing ischemia, viable myocardium. Now you can't actually like get it in the exam, so it usually doesn't come in the exam anyway. So we talked about the first line management of ACS. So oxygen, IV line, nitrate, aspirin, morphine. If angioplasty is unachievable, either through timing or unavailability, thrombolysis is an indication for ST elevated MI, and the sooner the better, but preferably within 12 hours. So that's what we have discussed as well. Once all these things are done, the second line management or further management will be full heparinization. So you would be using low molecular weight heparin. And then after the management, patient will be continued with aspirin, clopidogrel, beta blocker, nitrate. So these are all after the treatment, which means after the stent has been done. Okay. So they talked about few of the other risk factors. They talked about few of the complications after MI. So the same thing that we discussed. And this is about the aortic dissection. Okay, so that's mostly like all that is in John Murtagh. The only thing that you can read from John Murtagh is the stable angina management. Okay, and that is more than enough for your chest pain preparation. So for acute angina, you give nitrate, Dr. Tamanna. And if it is like a preventative, like not acute angina, so for prevention, aspirin, beta blocker, then nitrate. We always do troponin I. Troponin T is not done. All right. So that's all for chest pain, guys. Do you guys have any questions for today? Dr. Samin, that's for just chest pain. So for chest pain, if you just read the note and the JM stable angina, that's enough. I always say that the important topics, it is better to read from John Murtagh at least once. Like chest pain is an important topic. So read it if you can, but it's not must because we discussed everything that is there anyway. Handbook and QBank is not same, Dr. Walid. So handbook is like the AMC handbook, where there are lots of questions of different things. That is actually for like that is done by AMC itself. QBanks are different. We will share the QBank in your Facebook course group once you join the course, and you'll be able to see lots of questions from different subjects are there. It is the Kaplan Step 2 CK, which is different for different subject, not the master the board. Dr. Asma, we already shared all the class schedule for this free 2-week session. So you can easily find out in our first aid AMC MCQ group if you can. You go to our state here. Okay. So have you go through that and you'll be seeing all the schedules over here and with the timing and everything. Dr. Nimasha, yes, if you have only 2 months of your exam, you can get into the course and you can go through all the recordings. So once we start the course, at the moment already you have access, like any of our course student has access to the previous batch recording. So anyone who wants to finish the course within 2 months, they can easily go through the past class recording and finish the course in the shortest time. Video will be uploaded usually 24 to 48 hours after the class. Yes, so initial investigation for most of the patient with chest pain is ECG. Yes, you will get a full schedule for your study after 2 weeks. How many mocks? So for all the subjective, you get only one. So cardiology mock tests are only one, but you can appear it multiple times if you want. I would definitely not say that 3 months is enough for a first time appearing candidate who is a beginner. For beginner, you should take a little bit more time. So 3 months, I don't think it is enough. Dr. Asma, the previous lectures are like this. So cardiology. So you know that like in cardiology, what we are going to discuss. I don't know like what kind of list we can provide for that. It's already written. So in all the previous lectures, there is already written cardiology class 1, cardiology class 2. So the topics, like it's really not very fruitful to write the topics like that in anywhere. So you would need to go through both cardiology anyway. So you will find out when you watch the recording. Okay. No, mock tests are multiple attempt. There is no separate recall course. It's a part of our 5 months course. Yes, so there will be a separate class for ECG, but that's not a part of the 2 weeks course. After 2 weeks, we will do the ECG class. I don't think we have uploaded the Q bank yet, but you can have a look into that PDF section that we have uploaded. The best tip for anyone who goes through AMC MCQ, Dr. Niraj, is it's not something which you can hurry and just pass the exam. You have to go through the process. Gradually, you will understand what is important and what is not important. Initially, people write everything in their notebook. And after 5 months, they don't even open their notebook. So the thing is that understanding what is important, and no one needs to make a note. Don't make a note. If you really need, just write the most important things, because those notes you will not even use after 5 months or before your exam. So ideally start taking notes after a couple of months when you become more oriented to your preparation. Now what you can do, initially I always say finish as much theory as you can. So if you are going with the live classes with me, then just go with me. If you have some time in between, still after that, go through the previous class recording and finish some of the previous batch question solve. Okay? And get an understanding about how to do the question solve as well in between. Okay? But after 2 months, your theory knowledge will improve. Then you will start to give more time with question solve and going through some of the recalls. But initially, I would definitely say, don't bother too much about the recall. Start the theory, get a basic knowledge, and just do the recall classes that we are taking. And gradually, you will understand the fact. Okay, so it is a gradual process. No one can be confident within a month. It is very unusual. But with time, with with a bit of preparation, with your hard work, AMC Part 1 is something that is doable. Okay, it is not a hard exam that you can't pass. Most of our candidate, 90% candidate pass in the first attempt. The only people who might fail is the people who takes 2 or 3 months for the exam preparation. They don't even come to the live classes. They just want to appear the exam. For those students, I can't say anything because you need to give time to prepare. Without preparation, if you go for exam and if you fail, that is up to you. Because we advise for you to finish everything before you go for your exam. Okay? So if you do that, there is no way you can fail this exam. Yes, so cardiology class, so two cardiology class will be enough for cardiology, and we also will have another ECG class. So usually it is a 3 class. So with that, everything will be covered. Yes, all classes that we take, we have recordings, so it will be available. And class is enough. Few things we asked you to read from JM, so you just do that. That will be okay. After the lecture, I would say go through the lecture again, like the note only. If you have done the live session, go through the note, find out if you can remember everything that we have discussed. And for important topic, yes, it is a good idea to read John Murtagh. The video will be uploaded. There is a Telegram group, but it will be added. It will be added after free 2 week session is done. No, Dr. Aisha, you don't need to read the full John Murtagh. It is not a smart way to read at all. So the only thing that we ask you to read, that's only thing you would need to. But most of the things that actually needed will be discussed in the class. Yes, so the 5 months class covers theory classes, the question solve classes, everything. A score has nothing to do with the job. Telegram group, you can always join a Telegram group just to get some idea about the questions. But like the question solve classes, when you start doing the course, you will understand that the portal has everything. Portal has like a thousands of questions already solved. So usually if you are diligent enough and you keep your eyes and ears open, you don't need to be on a lot of groups. You make a group of 5 people and you can do some question solve with them. You can read with them. So that's fine, having some study partner. And sometimes you can get joined with some bigger groups like Telegram or WhatsApp group just to see what people are doing. That's it. The notes will be added to the portal. The recall classes are taken by some of the other mentors. You will get classes with them. So for today's lecture from John Murtagh, I would say just read once. So just read the chest pain chapter once. Okay, that's enough. You don't need to memorize anything. Just read it once. The full chapter. Did you join the course, Dr. Jainab? I'm not sure about the WhatsApp group, Dr. Tamanna. So many of our students, they make one for them once they join the batch. So these are usually after 2 weeks session are done. We don't usually do any of this in this initial 2 weeks time. How many months are enough? So ideally 5 to 6 months is enough for preparation. It is not true. So you can't actually say, you can't think that just few days are better as an exam day. Those are all myth. Yes, Dr. Noor. So doing the classes, notes, and MCQ, it is enough for the exam. All right, guys. So that's it for tonight. I hope that you guys are enjoying the session. If you guys want to know a little bit more about the course, so everything is given in our Facebook group. So join the Facebook group, which is First Aid AMC MCQ. And if you go to the featured section of this group, so this featured section, you will be able to look into all the course details. So we have written everything. Any questions you have, most of these are discussed in here. So what the course includes, like theory, 5-year sample discussion, we have mock test, QBank. So everything is written in here in detail. So you can definitely go through this and see if this is what you want. Okay. Here tonight. So your next class will be on 16th, which will be, I think, Friday. So you'll be finishing the cardiology class 2. Okay. Thanks all. Have a good night. Take care. Bye.